streaming everywhere. And we are live. And hello, Dr. Rachel Hines. It has been such a long time since we've spoken. Are you well?
I'm well, thank you. How are you, Fiona?
Well,
Nice to see
apart from hopping onto the wrong
you.
thing, no sleep, I'm very, very well. And this all comes back to menopause and HRT, and you are one of the perfect people to speak to about this, because not only are you an incredibly busy GP at the Claire Mellon Centre Clinic, whatever it is, in the Portland Hospital, you're also you are incredibly busy, aren't you? The clinical director for Vira, which most people will probably know from Stella, the app online. So you're dealing with patients on multiple platforms all the time, who obviously have lots and lots and lots and lots and lots of horrendous symptoms, which when people sort of come to you, I mean, when they say, I think I need HRT, what are they mostly presenting with?
So as you just said, sleep is or lack of sleep when you're insomnia is a really common presenting symptom. And sometimes it can be that you're managing all your other symptoms, and then when your sleep goes, then that can really prompt women to come when they're not sleeping well. Hot flushes and night sweats, low mood and sort of irritability, rage are probably the most common. I would have thought anxiety. And then obviously once you start getting a combination of factors as well. So yeah, it really does vary, but sleep is a really common prompt.
Yeah, it really is, isn't it? It's interesting because I don't know whether you know, but I get incensed quite easily. And when the government came out with the research into reproductive health, and they started it at age 16 and finished it at age 55, I kind of thought, hang on one second, there are 11 million of us who are over 55. So I thought I would do my own survey. So I've been analysing that recently, the first 110 responses. And sleep was, and this is 55 to 79-year-olds, was the biggest thing they complained about.
Yeah, I'm not surprised at all. As in practice, it really is what you see, because you can manage everything else, but if you're not sleeping, like from experience, it makes everything so much more difficult to manage, and you can't concentrate, you can't focus. It can make other menopausal symptoms worse. So particularly, another big one is lack of concentration and brain fog. And so if you're struggling with concentration anyway, and then you're getting either broken sleep, or you can't fall asleep, stay asleep, or a combination of these, it can make it so much more difficult to function during the day.
You just can't concentrate, especially if you're getting up, 4 or 5 times a night to go to the loo. You're doing a whole bunch of this. Excuse these boxes behind me. I'm in the office. Stress urinary incontinence, getting up all night, low mood, anxiety, all of those sorts of things just seem to feed into. I mean, you can't sleep well when you have all of those things, really, can you?
No, exactly. And then because there are so many reasons to wake you. And like you say, if you're needing to go to the toilet several times overnight, is really difficult if you're having anxiety. So if you do wake up and then you start ruminating, and then you're having it, finding difficulty falling asleep, or you're woken up by night sweats, and then you've got to change your bedclothes, change your pajamas, like have a shower even. It can be just so disruptive. And then if you're having difficulty with your sleep, then it's difficult to fall back asleep again after as well.
Yes. And then you lie awake thinking, put it this way, I woke up because a dog barked at 10 minutes to 3. And then by about 10 to 7, I was thinking, if I go back to sleep again now, she's got to bark at 7:30, because she does every morning when the kid goes to school. So then you get this stress, anxiety going in, of like you've spent 3.5 hours awake, arguing in your brain about everything on earth. And then you think, well, I can't go back to sleep, because as soon as I go back to sleep, the dog's going to bark. And it's horrendous. But there you go. Sleep aside, we had a number of questions come in, and they're all actually really interesting, and they go back to some quite basics about HRT. And so let me throw a couple of the ones that came in at you. And one of them is a 55-year-old woman who was asking, she's postmenopausal and she's thinking about starting menopause. So what dose would she need? How would she start, and how does she know what she actually needs?
So if you're postmenopausal, so it depends on so the average age of menopause is 51, meaning the average age of last period is 50, roughly. So it depends, and the average length of postmenopausal symptoms is 4 years. So it depends where your menopause is and how long the individual symptoms can last for. And obviously it fluctuates and isn't always 4 years. But so it depends on how long symptoms are going to go on for. Assuming you're a few years postmenopausal, I would start on a low dose of estrogen, because you may only need a bit to treat symptoms, and then it could be increased as needed. So that would be either a 25 patch. So if you're having, so you need estrogen to treat your symptoms, and then you need progesterone as well, because estrogen by itself can make the lining of the uterus get thicker. And so it would depend what type of HRT you're wanting to use. But I would start on a low dose of estrogen, and it can be increased up as needed. And then obviously depending on what progesterone is being used with it.
Yeah. Then the other question that came in about that was on the end of it was, when do you stop? Now, this is an interesting one because I've been seeing quite a lot of posts actually about women saying, my doctor told me I had to stop because I've been on it for 5 years. My doctor told me I had to stop because I'm over 60. So is there any time when you have to stop, or is this one of those myths that needs to be buried?
Well, previously, as in that, like, we used to prescribe for 5 years, and at that point it was thought your breast cancer risk was too high and you could take it for 5 years and then it would be stopped at that point. The current NICE guidelines are to review annually. There isn't an endpoint fixed at which you need to stop taking it. As you said, over 60 there are increased risks. Generally, so our natural risk of breast cancer increases, your clot risk increases, and also stroke with age. And if you're on HRT, it might be, if you're on oral HRT, we prefer you to be on transdermal, so having the estrogen through the skin. Taking estrogen orally increases the risk of blood clots, and so therefore it's much safer having it through the skin. So you may be suggested to change your HRT at that point. And what was the other you said about age and?
The over 60 as well. You've got to stop once you reach 60.
Yes, you don't need to stop over 60, and you don't need to stop after 5 years. So it may be that changes could be made to make it safer for you, and particularly switching from oral to transdermal. But it doesn't mean you need to stop taking it. You might be able to reduce your dose of estrogen as you get older, and certainly we like you to be on the lowest effective dose of HRT, and that completely varies from person to person what that needs to be. But yeah, the 5-year cutoff shouldn't really be a factor anymore, to be honest.
Yeah. With the you mentioned blood clots there. We had a question come in about blood clots as well, and the safety of HRT if you have an unprovoked blood clot. So it might be useful to explain what different types of blood clots there are. Are there certain conditions, bleeding conditions, that might mean that you couldn't take HRT, or certain clotting ones that you mean you might? Because we often see as well, we know that transdermal is safer, and if you have a DVT that you've got from sitting on a plane or something for too long, you probably really shouldn't have a problem. But therefore people then go on to say, well, everybody who's had a clot is perfectly safe on HRT. But is that necessarily the case?
So it depends, exactly as you say. So whether it's a provoked clot, so a blood clot on your legs, so a deep vein thrombosis, or on your chest, which is a pulmonary embolus, and if it's following a long flight following surgery, it's called provoked. If you get an unprovoked DVT or PE, so there isn't any known reason for getting a clot, is likely to be much higher risk. And it depends if you've got clotting disorders, and so things like thrombophilia, factor V Leiden, like there's lots of different conditions that can increase your risk of having a blood clot. And having estrogen as a tablet, so having it orally, it gets broken down in the liver, and that can affect your clotting pathways. So therefore having oral HRT always will increase the risk of blood clot. The type of estrogen and the type of progesterone influence that risk, and there are some that are higher risk than others. Like you say, if you've had a provoked DVT, it's likely you can have transdermal HRT and that will be safe. But if you're in one of the higher risk categories, you may be able to have it, but we might need to discuss it with a haematologist first, just to see if there's any additional tests. Sometimes you might need to have it with an anticoagulant as well, so something like warfarin alongside. So it's really individualized. So if you're at higher risk, it does need to be looked in a bit more carefully, but it doesn't mean you can't have it. But it might need to be managed a bit differently.
It's a very complicated thing, isn't it?
It
is when we're talking about complication. There are a couple of questions here about periods. Now, one woman was asking, was saying she started HRT and her periods returned, and another woman is asking, and she wants to know when they're going to stop. And the other woman was asking, will HRT bring my periods back? So does this go to the sort of root of sequential versus continuous HRT?
Yes.
And what does that actually mean?
So it depends. When you have HRT, you need estrogen to treat symptoms, as I said, and progesterone is to stop the lining of the uterus getting thicker. And it depends where you are in your menopause whether you have cyclical or sequential, which is when you have progesterone for half the month, or whether you have progesterone continuously. If you're within a year, if you've had a period within the last year, you would usually start on sequential HRT, so progesterone for half the month. If you haven't had a period for over a year, usually you would start on continuous in quite a sort of basic way. And so if you've had a period, you know, say you've only had a couple in the last year, you may well be started on sequential, and that might give you a monthly bleed again because you'll get a withdrawal bleed to the progesterone. So it varies in terms of what we use. And then once you've been on cyclic HRT either for 5 years, or if you reach the age of kind of 53, 54, you'd be switched on to continuous. And sometimes we would use continuous sooner as well. So you may well go back to having a regular cycle, having had very sporadic periods.
This one really tricks people, doesn't it? And the other complicating factor then is if you were having periods before you started, and not just once it sort of came back because you were doing sequential. Either way, at some stage, when do you stop thinking about contraception as well?
So contraception is really important and always needs to be considered, because if you have your last period under the age of 50, you need to use contraception for 2 years after. And if you have your last period over the age of 50, you still need to use contraception for a year after, because even though you think you're menopausal, you may well still ovulate. So it's really important to be careful. And HRT is not contraceptive. If you have a Mirena, IUD, so a Mirena coil, that can be used for the progesterone part of your contraception. It needs changing every 5 years, but that can give you the progesterone you need for HRT and contraception, which is why it works so well when you're kind of mid-age, because it covers both. So, but then obviously it may be that some women have a Mirena and their periods stop with the Mirena, so you don't actually know where your menopause is. So it kind of adds an extra layer in, really.
Yes, it does, doesn't it? Yes, it's a very, very tricky one as well. Speaking of bleeding, which, as you mentioned, Marina, another woman asked, actually, she started HRT and she's bleeding continuously. How does she stop it? So how do you get that balance? So, and I don't know whether you know, but I have dubbed last year, and probably this year as well, the year of bleeding endlessly, because I had a Mirena coil. I had it taken out because it had done its 5 years worth of, I'm sorry if people have heard this a million times before, because it had done its 5 years worth of work. And then because I'm over 55, they said that you can't have it because you can only get it on the NHS for contraception. So I had bled like no tomorrow for the entire year, pretty much. Finally managed to get the Mirena coil put back in last August, and still are continuing to bleed. So I sympathise with this woman. Bleeding, unresolved bleeding on HRT. What do you do?
It's really common, and there are more and more women being referred because of it. So we always advise when you start HRT, you can get some irregular bleeding. And essentially it's from the impact that the progesterone has on the endometrium, so the lining of the uterus. If you're having it cyclically, we give it in this, usually, there are different regimes, but I usually give it in the second half of the cycle. So it coincides with when your progesterone naturally goes up, and then you stop taking the progesterone, and then you will have a period and withdrawal bleed from the hormones as well. So it's kind of trying to sync that. It can be difficult to get it exactly in sync, which can cause irregular bleeding. Different types of progesterone can give better control of your bleeding as well. So Utrogestan, which is body identical progesterone, has lots of benefits, but it doesn't always give the best bleeding pattern. And actually, we really commonly use transdermal estrogen, so estrogen through your skin, but progesterone as a tablet. And splitting them up also can give a less good control of bleeding. And what you described does happen quite often. So you can get the dysfunctional bleeding, you don't know why. And then because the lining of the uterus is slightly thicker, you put the Mirena in, and it can take quite a while for it to become thin again, and then the bleeding to stop. So it often can be trial and error with progesterone, and it's the progesterone that causes it. Whenever you change dose of estrogen, that can also cause bleeding as well. So it's anything that can impact the endometrium. And sometimes it is trial and error until you get the right dose that suits you, which obviously can be really frustrating in the meantime. And you may need to have investigations and scans and hysteroscopies in the meantime. So it's not always straightforward. Some women are really lucky and you start HRT and it's totally fine and there's no problems. And others, the bleeding can be a problem.
Yeah, and
So,
which goes to the question from Ewe over here saying, if you have a Mirena coil and you have that bleeding, can you use Utrogestan simultaneously as well?
you could. There's no particular need, and to be honest, if you are having problematic bleeding from Mirena, Utrogestan wouldn't necessarily be the first choice to use. It can be used, absolutely can be used. If you're wanting to get better control, you might be better using another synthetic progesterone alongside, but you could use Vira. And sometimes when you fit a Mirena, I will continue on HRT in the mean. So say if I was fitting a Mirena and someone was using a combined HRT, I would continue the progesterone for the first month or two to try and limit bleeding or stop it happening. So it can be used. It's not something you necessarily do routinely. But if your Mirena has run out, so if you could use there's new guidelines for Mirena have come out last week. So you can now use, if you're under the age of 45, you can use a Mirena for 8 years for contraception, but only 5 years for HRT. So in that circumstance, you could definitely use the Utrogestan for your progesterone as well, and if also it needs to be done every 5 years. So you could have a Mirena in place for contraception and then have Utrogestan for your Vira if it's over 5 years.
This is the interesting. I think we have the crux of the matter here. Is bleeding is not her issue really. She's missing because this is the night. If you get on well with progesterone with the Utrogestan, it's really lovely, isn't it? I unfortunately was one of those people who did not get on well with it. It made me moody. It made me want to kill everybody inside, which is really like the last thing I need for a relatively fiery person. It gave me reflux. It was not for me, and even vaginally. Yeah. It wasn't great, but Ewe is saying it's the sleep and the calming that she misses. She found exactly the opposite of what I got. So if you did get that benefit and you have a Mirena, could you have one at night, and or is this just like going too far?
Yeah, I mean, you could do. Again, it's not something you would do routinely. I think being mindful of breast cancer risk as well. So we know that there is a small increased breast cancer risk with Mirena, so small but present. Utrogestan, it's thought for the first 5 years there isn't an increased risk of breast cancer. So it kind of depends where you are and how long you've been taking it for. And certainly it is used alongside, not as a routine, like not necessarily as a routine measure. And you don't need, if you're within your 5 years, you don't need to have both. But some women do get on really well with having more progesterone. So
yes.
I think
at the other end of the scale, then, though, for the people who don't get on well, how do you balance them? How do you know if you? I mean, obviously, it was obvious to me that I wasn't getting on well with it because obviously it was a quick and sudden change, and that was the only thing that was different. But if you're starting HRT, and perhaps if you've got a history of PMS or PMDD, how do you balance that? Because that's a really difficult one, isn't it?
Yeah, so in terms of the progesterone that's used, Utrogestan is usually the best tolerated, but obviously it varies. So the body identical one. Some women find that they don't get on with it in the way that you described, and it can be used off license vaginally. So you can use the same dose vaginally. It's not licensed, but it can be used as an alternative. Normally we use progesterone for 12 to 14 days a month. If it's cyclical, so you'd go for the 12 days. There are some other ways of using it as well, and sometimes you would use it less frequently. But you may need to have scans, like at least on a yearly basis, to be able to check the lining of the uterus to make sure that it's being kept thin. So that can be used, and sometimes there are again other off-license things that we can do occasionally. So you may use the progesterone only pill and double the dose of that. So and if that suits you, so there are other ways that you can do, but it's trying different progesterones, and actually, so you can have it obviously orally as the Utrogestan. It's combined in a patch with Everol, and there's Vira and norethistron. So there are a few different types that can be tried, and also oral HRT, Femistone. Women often get on really well with the progesterone that's in. That's called dydrogesterone. So again, sometimes it may just be that it doesn't mean that you can't take all progesterone, but it's needing to find the one that's right for you. And if you're having really significant side effects, do speak to your doctor sooner or nurse rather than later, because it can have a really detrimental impact. And again, the women that find oral progesterone absolutely awful get on really well with the Mirena. So that's always to consider, that you could have the intrauterine progesterone as well.
Yeah. You mentioned before this, when you started, can sometimes be a trial and error to find out what's right for you. We had one question that came in that was saying, can HRT cause anxiety? And she's saying it's worse in the mornings for her. And because I think we have this sort of general perception, we're sort of told that you need HRT. HRT is going to solve all of your problems, and you'll be fine very quickly. But that isn't always the case. And so when you find that you go on this and you suddenly start to have other sorts of things, is it the dose? Is it the type? How do you work it out?
So it can be a combination of things. So yes, HRT can cause anxiety. It can be both the estrogen and the progesterone. It could be the time of day. So estrogen can be quite stimulating, and it may be if you're using your HRT and then you're feeling anxious following it, it might be from that. If the dose of estrogen is too high, that can cause anxiety as well. So there's definitely things that can be causing it. So I generally start on a low dose and increase up to try and minimize side effects from that. But particularly if you've not been having anxiety as a menopausal symptom, then you start your HRT, and then it's trying to work out if it's the estrogen or the progesterone that's causing it. So if you're taking cyclical, so for the progesterone for half the month, that's usually much easier to tell where your side effects are coming from. If you're on continuous HRT, then it might be changing the time of day that you're having it, or changing the dose, and again changing the type of progesterone to see how that can be. But the sort of most common side effects when you start can be things like breast tenderness, skin changes, mood changes, and headaches. And so just giving it a bit of time to settle. So unless you're feeling absolutely dreadful, give it a few weeks to see if it settles down. But obviously if it's getting worse, then be reviewed in the meantime.
Yeah. And when you say skin changes, what types of skin changes do people often see? Because I mean, you have, I don't know whether you've noticed, but you have an expectation that if you're taking HRT, you're going to look youthful and glowy for the rest of your life, which may not necessarily be the case. And we also, I seem to be seeing all over the place, an endless number of products coming onto the market, compounds, saying, put this on your face. It's perfectly safe. You can put it on your face. And so, well, hang on a second. This area, slathered on quite thickly, is a lot larger than my labia, so which I probably wouldn't do every day. So, do we know putting it on our face is actually safe?
There are so many skin products now, and it's just like for menopause, or like seeing it's like menopause skincare. I don't.
Yeah.
But in terms of negative.
Too. These are the ones with the estrogen in them, estradiol in them. I think they're about 100, somewhere between about 99 and 149 pounds a pot. Wow.
I don't think I'd put it all over my face. I suppose it depends on the concentration, but there's no need to put estrogen all over your face, especially if you're using it through your skin. Right? Or as a tablet, you don't need to do that, in my view. But in terms of, you can get...
You're going to your skin anyway, so what would be the point? You'd like double dosing?
Yeah, I don't see the point in doing that at all. Oh, I was thinking more just of the blander ones that just say, you're getting older, have some thicker skin cream, and calling it menopause.
But they've got the everybody seems to be very excited about they've got a soy isoflavone extract or something in them, which I'm not really sure has a huge amount of evidence behind it when it comes to skin absorption and collagen production. But
yeah, I suppose if it doesn't make it worse, it might be helpful. But I mean, you can definitely get more acne. So in menopause, you can experience spots when you've not had them before, or if you've had them before, it can easily recur. And particularly when you start HRT, you can find that you're breaking out, which does usually settle. From a positive perspective, HRT often does have a positive impact on skin, because exactly as you say, sort of increases the plumpness of the cells and can help with your collagen production. So often women will find that their skin feels much softer, and if it's been feeling dry, it may feel much back to normal again when you start it, which can be really helpful. So the negative side effects tend to be kind of spottiness, but there can be positives as well, and it really can help. And I don't know necessarily about glowing, but if the texture of your skin improves, and the general overall sort of moisture of the skin, then it obviously does make you look better from having it.
Yes. The other thing that people often complain about with skin is that intense itching, the formication, not to be confused with fornication, which would be a lot more fun.
Absolutely. Yeah.
What is it about that itching, especially it seems to be the calves on a lot of people, or the back of the arms? What is it about that? Why?
Don't really know.
The skin off.
Yes, I mean, you have estrogen receptors basically all over our body. And so therefore, when your estrogen levels are fluctuating or falling, it can give rise to a really wide variety of some quite odd symptoms and things like restless leg syndrome. So when you need to get up over, like when you need to get up at night and you just have to walk around because your legs feel you've got to move. And like, as you say, itching and crawling and lots of like electric shock sensation people describe. So there's so many different symptoms that can come, and essentially it's all to do with your estrogen. And obviously you have a variation of progesterone and testosterone as well, but it's from the changing hormonal levels. So you can have, it's always really good to see, especially if you have been having lots of different random symptoms that may well have been investigated, and you start HRT and they stop, because that does happen. It's, you know, that's always really good when it happens, because especially if you're going, I've just got this really weird itching, or my bloods are normal, everything's totally fine, and then you have some estrogen and it goes.
Yeah, some good things you mentioned there actually, and that is in terms of you know, people always talk as well about they you know, do I need a blood test? You know, my levels are low, but my GP doesn't believe me. Who needs a blood test, and when do levels matter?
So if you're under 40, you need to have bloods. So if your periods have stopped, or you're having very irregular periods, you need to do blood tests to check FSH, so follicular stimulating hormone levels. You'd look at your thyroid and prolactin, amongst other things as well. In terms of guidelines, age 40 to 45, you consider doing bloods, and it varies. So on what the history is, and like on an individual case. Over 45, recommendations are that you don't need to do blood tests to diagnose menopause or perimenopause. There are situations where you do them, and particularly it can be if you have a Mirena and you don't have periods, but you're having some symptoms, then you may well check to see if you are menopausal, or whether it's something else that could be causing the symptoms. So yeah, hard and fast is under 40, definitely. 40 to 45 maybe, and sometimes over 45 is usually what we do. Yeah. And then otherwise, if you're on, other times that I do check blood, so if you're on, you know, a higher dose of estrogen, but you're still having ongoing symptoms, you may want to check an estradiol to see if you're absorbing, to see if it's actually, if it is working. If you're on a high dose, but you still don't seem to be getting any benefit from it, you want to check that the levels, that it's actually going in. So yeah, so routinely though, very often.
We tend to, there seems to be a lot of support these days for interesting ways of handling your. You would normally think you're taking HRT to try to smooth out those fluctuations so you don't have your symptoms, but there seem to be a lot of people these days who go, I don't feel very well today, I'm going to up my dose. I'm a bit tired today, I'm going to add a bit more. I think one of the most interesting one was, I've got sore fingers, I'm going to increase my dose from 5 to 6 months. So we seem to have a kind of theory where you can just keep on adding, and then a lot of people say, well, I have to keep on adding because I'm not absorbing well. But if you're not absorbing well, then why would you not change what you're on?
Change. So if you were on it, it does vary, and like you say, so sometimes I think if you've been taking it for a while and you recognize that your symptoms are coming back, you should do it in conjunction with whoever's prescribing for you. But I mean, sometimes you do discuss it before, just going, you know, if it's coming back, you can add an extra dose. But the maximum licensed doses are 100 microgram patch of estrogen or 4 pumps of the gel. And the maximum licensed spray is 3 sprays, but that is actually a much lower dose than the other 2. And if you're finding that you're on 4 pumps of gel and you're still having lots of symptoms, you should check the levels, but it may well be that you would absorb much better from a patch, and you can have the same dose and you would be much better with a patch, or orally, like having it as an oral tablet. And everyone does absorb differently, and if you can get on really well with one method. We saw it lots when there've been shortages and you're switched from one to another, and it could even be from one brand of patch to another that you don't absorb as well. So it doesn't mean that you need to keep on going higher and higher in the dose, certainly not, because then you can get side effects from having the higher doses. Some women just don't absorb very well, and it can be that you are in a higher dose and you check the levels and they are quite low, and that's the best choice for them. For example, if you're having migraines and you're having patches, and that gives you good control of migraines. So sometimes you do need to be, but not very often, if you're needing to go above, but often, changing the method can be really, really helpful.
Yeah. The other thing that comes out of that is too, is if you are having, symptoms that you think are menopausal, there are also a number of things, as you mentioned before, ruling out other conditions. What
Yeah.
sorts of things would be, I mean, things like, people say, I'm always cold, my joints are still aching, I'm still feeling tired,
Yeah.
things like that. But what other kinds of things could be contributing factors to those that mimic menopause symptoms, I guess?
Yeah, so you always need to think about thyroid. So if you're having fatigue, if you're feeling cold, if your joints hurting, think about having an underactive thyroid. Another thing that's always really important in my experience to think about is rheumatoid arthritis, because it develops in mid-age. And if you're having, sort of lots of joint pain, so it's one thing saying, oh, my shoulder hurts or my hip hurts, but actually if you're getting lots of small joint pain or redness or swelling, it's all, you have to consider that it's not always menopause. And particularly once you're on a good dose of HRT and going, I've got this, and this, it's really important not to assume everything is a menopausal symptom, and may need to investigate otherwise. There can be things like vitamin B12 deficiency, or if your iron levels are low, there's so many different causes of different symptoms. But yeah, especially once you're settled on a dose, if it's a recurrence of previous symptoms, okay, but if you're developing new symptoms, you need to have a level of suspicion that there could be another cause there anyway.
Yeah,
So,
it's interesting you mentioned the iron, because I mean, I guess one of the main symptoms. Well, actually, I didn't have this, but they say you've got to have the period changes, and those period changes, they can be heavy, they can be closer together, they can be further apart, but basically you'll be bleeding. And in that, how many women do you think are probably wandering around not knowing that they could possibly be anemic, and a lot of their fatigue and stuff could be because of that?
Oh, absolutely. And also in terms of things like your hair, so hair loss and skin being very dry, nails being dry and brittle, it's thought ferritin, which reflects your iron storage, the levels should be over 70, and they're not that often. So when you're checking, if you've got a low iron, and it's something that's easily treatable. But if you're having heavy periods, or you're having periods all the time, it's not unusual to become anemic from that. And exactly, you don't know, and you're like, it's because I'm menopausal and I'm knackered. It's like, well, it may well be, but actually it's because your iron levels are low as well. So
and with my year of bleeding endlessly, that's what I noticed. They actually got to a couple of months ago. I mean, I'm sorry again if people have heard me say this, but I live on the first floor. I do go to the gym. I do exercise. I walk about 5K a day. And just to walk up that flight of stairs, I get to the top and I go, God, my legs just feel like I've run a marathon. And, at 3 o'clock in the afternoon, I'd be thinking I need a nana nap, and I'd be yawning all day. Hair started falling out. Nails were breaking. And, fortunately, I was talking to a friend of my GP friend of mine. He said, you should be on iron. So it's sort of like, oh, you think that's what it is? So and literally within about 2 days of starting that iron supplement, I could walk up the stairs and not feel like my legs were like a dead weight.
I mean, that's amazing. And I think women just put up with so much, and you just say, oh, well, I'm menopausal, this is meant to happen. It's like, well, it is normal in the sense of if your periods are changing, but you shouldn't have the accompanying, like, I need to go to sleep at 3 o'clock feeling. And I think it's knowing when to seek help and say, that's not normal. It's out of the realms of what I should be experiencing. It's so important.
Which differs to your energy levels. And I have 2 questions here, and I will take the first one first, and I'll come back to the other one. What can you do if your ferritin doesn't rise with iron tablets?
So it depends on what the tablets are. Not everyone absorbs very well, so it might be needing to have a different iron tablet, and sometimes needing an iron infusion if it's really just not absorbing. It depends on what the dose of iron is that you're taking. So it may just be that it needs to be increased to try and do it a bit more quickly. So normally if I was treating iron, I would check it at 3 months, or ferritin, you'd recheck the levels 3 months later and see where you are with it. Sometimes it can just take longer to pick up, but if it really wasn't, and if you're very symptomatic, then you can consider doing an iron infusion as well.
This is what Sam is just saying here. My ferritin is 15, but because the lab says it's within the normal range, nobody's picked it up.
Yeah, because it will come back as being reported as normal. So it's important as in knowing in terms of what the levels are. So yes, you'll get your normal range, because also ferritin goes up in inflammation. So it can be, you'll get heightened awareness at the other end. So if you've got really high ferritins, we follow that up for totally different reasons. But so if the ferritin's within the normal range, but if you're not looking for it, then you'll go, that's normal, and wouldn't then act on it. But it does help increasing the ferritin.
There you go. Now back to estrogen. The question up here that I skipped past but are now going back to is how long should it take for estrogen to start working?
So 3 months always say check at 3 months. So some people can find it helps really quickly, and it really can be like I started using the gel 2 or 3 days later, you could notice the improvement, but it can take up to 3 months. So having the expectation of 3 months and then being happy if it happens sooner, basically. So it's, yeah, and then you would always, whenever you make hormonal changes, usually it's every 3 months. So you like give it 3 months to try. So with estrogen and with testosterone as well, you'd be looking to.
And that was my next question for you. Testosterone, since we've beautifully segued into that. Who needs testosterone and when would they normally start it, and what tests do you need for that?
Yeah, so I was thinking this when we were just talking about blood tests before. The other tests that you do are for testosterone if you're having testosterone therapy. So the kind of, it's not a licensed medication for menopause, but in terms of the reasons for giving it are to treat low libido, and that's the indication for giving testosterone. There are other women find that there are lots of other benefits from it, but the main reason for giving it is libido, but many women find it can help with their energy levels and their mood and concentration, stamina, but there's research ongoing into that. When you would start it, so low libido is a common symptom in menopause. It's also important to treat vaginal dryness, because if it's too painful to have sex, then you don't want to, which can impact on libido as well. But if you're on HRT and your other symptoms have resolved, and you're not really having ongoing symptoms, that's the point at which I would start testosterone, because then it can help with libido, and we know that the other symptoms are controlled. And we check testosterone levels, and you can also check when you're starting initially. Often you check the estradiol levels to make sure that you're in the range you would expect, and also you can also check something else, sex hormone binding globulin. And you check, which gives you something called the free androgen index, which shows how much testosterone you have available. And then usually you would start it, and then you would check the testosterone at 3 months to see where you are in the free androgen index again, because you need to make sure that you're within the range for testosterone to avoid getting side effects from it.
Yes, which is an important thing about whether or not to put it on if you're going for. If you have a GP who does tests, which I don't, but on the odd occasion when I've gone in and grabbed him by the lapels and said, "You need to test this," it's been 5 years. If you're going in to have it tested, should you use it that day or should you not? Because mine was like through the roof. It's like, my God, you're a walking. I'm surprised you don't have a penis.
So sometimes that does happen. You get results back of like a testosterone of 8, but if you don't use it on the morning of the test and have the testosterone level before 11 in the morning. And when you're applying it for 2 or 3 days before, be really, really careful with hand washing as well. But so just being careful, but it's before 11, and don't use testosterone on the morning of the test.
I think mine was doubly, because I applied here on the inside of my arm, sort of hair. So it was like 16 million sort of particles.
Yeah. Doctor phoning up going, "Hi, just free for a quick chat." Yeah. But no, so you often you apply it to either your bottom or your outer thigh. It can be applied on the inner arm. So particularly if you're having a blood test, do not do it on the morning, because it will affect the results. And once you're stable on it, if your symptoms are improved, then you can have bloods done sort of every 6 to 12 months. If you increase the dose of it, then you would check the bloods again after 3 months usually. It can be done from sort of 6 to 12 weeks, but more routinely you do it every 3 months to see until you're stable on it. And that tends to be a bit slower to improve than estrogen. So usually that tends to be more by the 3 months or even 6, to see if it does, if you do get a positive impact from it.
Yeah. In my spare time, I write for a thing called Health Ed Australia, which does CPD for doctors, and okay. I had to sort of combined thing with various experts in Australia talking about testosterone. And one of them was saying that in his experience, it works for around about 60% of people. Is that sort of where? Yeah.
Whenever I start it, you always counsel about the risk of potential side effects, and so but thinking about things like extra hair growth, acne, you can get hair thinning, like weight gain, and otherwise you can get deepening of the voice and enlargement of the clitoris, and the more significant side effects that we would worry about. But the other thing is that it might not work, and actually your testosterone levels don't always match what your symptoms are. So it can be, even once your testosterone levels are normal, that it wouldn't necessarily improve. So if you've been on it for 6 months and you've not seen any change, and we know the levels are right and the dose is right, then usually you'd stop taking it. Because
and
it
if you still had a low libido, then would you go on for counselling or some other types of treatment that was still an issue for you?
Yeah, absolutely. So psychosexual therapy and support's incredibly can be incredibly helpful and supportive. And it depends, there is obviously so many different issues around it, and relationships and looking at work and life. Pelvic floor physio can really help as well. So there's lots of different things and options, just seeing what treats. And also, as I said, really important to make sure that vaginal symptoms are treated as well, because that really can impact. So it's kind of looking at everything all together. So testosterone can be really, really helpful, and it makes a really big difference. Not in everyone. And therefore, so it's just treating quite holistically. And hope, if it doesn't work, not kind of losing hope and seeing what else you can do at that point.
Yeah, it's an interesting one, actually, because I mean, in this survey that I've been doing, 80% of women who'd had sex in the last 7 days said it was too painful. And across the whole spectrum, remember, this is 55 to 79-year-olds, that we always think, oh, well, the symptoms have gone by now. You're all right. You've gone through menopause. You're okay. It's like, no, we're not. We're really not. And 50% overall, so basically 27% of people have had sex in the last week.
Yeah.
33 hadn't had sex for more than a year, 33% of them. And overall, 50% of them said that it was too painful. And I can't remember the exact statistic, even though I did do this today, but I think it was around about 70, so close to the 70% mark of those who said sex was painful had symptoms of the dryness.
Yeah.
They had pain during and after sex. They had different things, but the vaginal dryness was about 60-70%.
Yeah.
What else did they have? Bacterial vaginosis, stress urinary incontinence, the tearing and bleeding. Another one was really high as well, close to the sort of in the 60s, or close to, I think, was that continuous itching and burning. So you think this is a huge swathe of women who are sitting around without the right treatment and really suffering.
It's so, I mean, that's really shocking figures, actually, but I think it's so important. So if you're going for a menopause consultation, if you're not asked about vaginal symptoms, even if it can feel a bit awkward or embarrassing, you should be asked. But if you're not, it's really important to just bring it up. See specifically about it, because using vaginal estrogen is so helpful, and it's low risk and safe, and there are lots of different types, and you can find what suits you, down to the type of applicator you have, whether you reuse it or have a washable one. There are so many different choices available now, but it really is important to get it treated. And if you're not being asked about it, then I would be brave and say, look, my libido is actually okay, but it's just too painful. I can't have sex. It's too hard.
Yeah.
And then, because you can buy it over the counter now, you can get Gina, so you can buy pessaries. But actually, it's far better to get it prescribed, because there's just far more options. And it's really effective, and you can use it long term. And you can use it without HRT. So you can use vaginal estrogen. You don't have to use systemic. So HRT in the body, you can have vaginal estrogen by itself, and it can be so effective and make such a big difference.
Decrease the risk of your UTIs, decrease the risk of vaginosis, huge amounts of things. Yes, I just want my E-string back, or S-string.
I know, them not being available is a real...
Yes, it's not pleasant. I'm coming up to a month without mine, and I'm not happy. I may have to start roaming the streets looking for women who look like they might have one.
Who's got? I think trying random pharmacists, because they may have a secret stash sometimes for when there's shortages. And I often get told just kind of local, brilliant little local pharmacies often have HRT supplies, whereas you think it'll be the big ones. But so that's always worth trying.
Yeah, you might be right. Absolutely. Lana's got a question here about Lenzetto. And this is an interesting thing, because I didn't know this actually until I know it when I learned something I didn't know. Apparently, it's sort of slow release. And so she's saying that, can we touch on how Lenzetto is different from the other forms of HRT estrogen? Why only 3 pumps when it's equivalent to a 50 milligram patch?
So it's absorbed. You get a kind of reservoir under the skin. So when you put it on, it's advised to put it on in the same sort of area. So if you're putting it on your arm, seeing where can I see myself? So if if you're doing 2 sprays, doing one 2, and it kind of builds exactly as you say, like with it being slow release, you get a residual amount coming through the skin. In terms of higher doses, it's not licensed above the 3 doses, and I'm unsure if that's in relation to studies, if it wasn't done as a higher dose, to see why it's not used above, because the equivalent dose is the same as higher doses we use with other types of HRT. But yeah, it is a slower release, so it should give you a steady release over the 24 hours ideally. You can split the doses as well, so like morning and evening, if you want. But yeah, apparently the best place for absorption is just above your knee, like inner thigh beneath the lower knee, or obviously inner arm as well.
I didn't know that. I mean, I put my Sandrina on in between my legs, so I can just do a sort of like little wiggle and rub it in together and be hands free. Fortunately, I don't have a thigh gap, so it's not an issue for me there.
Putting it together. With the Lenzetto, you just spray it where it goes. But good tip for the Sandrina.
Yes, it works quite well, actually. Now, somebody's asking as well, does sex hormone binding globulin affect how much estrogen you have available as well as testosterone?
So it's the estrogen that can affect your sex hormone binding globulin. And so particularly if you're taking oral estrogen, that can increase the SHBG, and that gives you less testosterone available. So it's kind of the opposite way around. So if you've got a low SHBG, you're more likely to have more estrogen available. But so oral HRT can suppress it. And other things that can impact is thyroid disease. So if you've got an overactive thyroid, that can affect, and liver disease as well. So there's different factors that can affect it, but certainly then that impacts how much estrogen is available.
Okay. And now I was actually asking, what day should bloods be done when you're on the patch, or also if you're on Lenzetto? Would it make any difference? I mean, I'm not sure whether her logic is because if you've got down on day 3 of your patch and you haven't changed it, is that going to give you some sort of wacky result? Or
yeah, it does make a difference. So ideally, I always say like it's kind of day 2, or like if you can with a patch, kind of doing it midway. And with Lenzetto and estradiol, waiting at least 4 hours after you've applied it. Don't have a blood test on the arm that you've applied it to. So doing it on the other arm, because then that can give really artificially raised results when you're checking. Yeah. But so if you use it in the morning, if you normally use it in the morning, don't use it that morning, and then that should be fine. Or if you've had it, wait at least 4 hours after checking.
And the other question she has is, if you had the choice between, I love when people ask questions, especially because the state of my brain at the moment, the more questions come from somebody else, the better. The other question is, if you had the choice between 3 sprays of Lenzetto and a 75 milligram patch, would technically the patch be a higher level?
So 3 sprays of Lenzetto is equivalent to a 50 microgram patch. So you would 50 micrograms is that, so a 75 microgram is probably 4 sprays, roughly 3.5, 4. So yeah, 4 and a bit sprays is equivalent to a 75.
Yeah, brilliant. All right. Yeah. One thing that doesn't get an awful lot of of airtime really is the Vyjuve, the new oral estrogen and progesterone. Yeah. Because I mean, normally when we think of taking estrogen orally, we think of the old-fashioned horse's pee, synthesized, not very nice ones. But this is the newer one. What do we know about its safety and its side effects and those sorts of things?
So Vyjuve is an oral estradiol, so it's a body identical estrogen, and it's the Progesterone. So it's an oral body identical progesterone. So it's a body identical progesterone. It's continuous HRT. So each tablet has estrogen and progesterone. So it's used in postmenopausal women. Or that's what it's licensed for postmenopausal women, or if you are switching over from cyclical to continuous. So it's a good option. It's not used very often. I think women really often do want to use transdermal. But in terms of risks, for the risk of DVT, you want it to be through the skin. And other things when we think about
identical, because that's what I was kind of wondering if it is a body identical one, does it? And is there a difference between the synthesis going through the liver of a synthetic estrogen as opposed to a body identical one?
So it should be lower risk of the estradiol. But if someone had a DVT, I wouldn't give them, and I still wouldn't give them Bijuve. But I think it's more just if you're at risk of DVT. So if you've got a BMI of over 30, or if you smoke, or other, there are other risk factors as well, you wouldn't necessarily use it. But otherwise, it is a really good option. So it's equivalent to either 2 pumps of gel or 3 sprays, or a 50 patch is the equivalent dose of it, and it's combined. It's easy to take, so it is it's a good choice to have, and for women that do want oral HRT, that prefer to take a tablet and are safe to do so, it's safer than the synthetic HRTs, and it also has a lower risk of breast cancer because you're using the body identical progesterone. So it's thought for the first 5 years the breast cancer risk is neutral with eutregestan. So therefore, if from that point of view, it is therefore safer than something like Femiston, like a combined HRT. So it's a really good option, but I don't think it's used very widely. In my experience, not many women want it.
No. And here's an interesting question as well. Sam is asking, are pellets also bioidentical? Now, we don't hear much about implants or pellets and those sorts of things. And I know that they're quite popular in the bioidentical compounded hormone world.
Yeah.
But what do we know about those, and what do we think?
So I've never used implants. When I did my training, I didn't use implants. The clinic where I did, and not many do. I think for some women they are absolutely fantastic, but I think they were getting tachyphylaxis, so when you're having higher levels of estrogen, and women were having symptoms from that, which I think is why they're not used particularly widely. So for some women who are still getting estrogen implants in certain clinics, they are really, really good, but it's just not widely used. I don't know how widely available it is. So I don't have experience in using them myself, but I know that they can be very good, but it's got to be quite carefully monitored.
And I think the difficulties is when somebody's asking you why aren't they used very often. I think, if they're not good, you've got real trouble getting rid of them.
Yeah, and having the access to be able to remove it, and you check your levels, and if they're sky high and you're symptomatic from it, then it makes it much more difficult to manage, which I think is why they've gone out of favour.
Yeah.
From using them. So yeah, in theory they are a brilliant idea because they last for 6 months, so you kind of sort it for the estrogen. But yeah, it's not something that I've used myself.
Yeah, yes, it's an interesting one, isn't it? Is there anything else? What stones have we left unturned? Or what stones are there? Any other stones that we haven't turned over?
I think the other thing that's new to be aware of that's not HRT is the fezolinetant, which is available from Monday, the 15th. So it's a non-hormonal drug, which is used for treating hot flushes and night sweats. So for women, going back to what we were saying before, actually, say you've had an unprovoked DVT and it's been deemed it's just not very safe for you to take it, it would be perfect. But it's only for hot flushes and night sweats. But it's a really exciting new development, actually, and having something additional that we can use to treat hot flushes and night sweats, because at the moment we've got antidepressants, gabapentin, but I think it's an exciting new development. So it's new, brand new in this country, like for 2 days it's been available. So I've got no experience in using it yet, but it's a new option for managing menopausal symptoms, which I think is really good to be able to have something else to offer.
Yeah, absolutely. Any tool in a toolkit is a good thing, especially for, as you say, those people who can't take HRT or don't want to take HRT, or because there are quite a few who can't take HRT. So
yes,
I know there was a lot of anger and outcry when they approved it, along with the outcry about CBT on being added to menopause treatment as an option. But
you need a variety, though. I think it's not just HRT, and CBT really can be really valuable in treating menopausal symptoms for women who can't take HRT, don't want to take HRT, but also for women that are on HRT. CBT can be really helpful as well. So kind of managing menopausal symptoms, but also thinking about what's going on around you in life. You're not like, sadly, sometimes not just in a bubble of you and your symptoms. You've got work and family and all sorts of pressures, and so therefore having CBT can be really valuable in helping.
Yeah, people get very good because they kind of think, well, it's a talking therapy, but it's got absolutely nothing to do with lying down on a sofa and going over past lives and traumas. I think it should be taught in schools. It's a resilience tool. in many ways, just to reframe the way you think about something. I've been through it for anxiety, and I think it's unbelievably valuable.
I think it's really helpful, and particularly not necessarily just CBT as well, things like mindfulness, but things that can help if you're having, if you're acutely having symptoms, if you're feeling very anxious, if you're experiencing panic attacks, you might be on hormonal therapy, but you might not be. And I think exactly as you say, having a toolkit where you can look for different things that can help, and managing things holistically, like exercise is really important, and finding ways that help you manage your own symptoms, because it is individual to everybody. So HRT can be incredibly helpful, but exactly as you say, you need more than that to give like overall support, I think.
Which was actually going to be my final question to you, because this is the thing, is we all think that, okay, once I'm on HRT, all of my symptoms will disappear, the world will be rosy again. But in theory, really, no amount of HRT is going to make up for an unhealthy lifestyle, is it?
No. I mean, lifestyle is really important, and things like with breast cancer, 1 in 4 breast cancers are related to lifestyle. And as much as everyone gets very, very worried about the risk of breast cancer with HRT, being overweight is far more significant than taking some hormonal therapy. There's the brilliant BMS chart, which I find so useful, the pictogram. It's just so helpful in going, well, if you're taking a combined synthetic, you'll get an extra 4 cases of breast cancer per 1,000 women per year, but there's an extra 20 something if you're overweight. So weight is important, and sort of helping, sort of managing weight, but exercise. So doing a combination of strength training, doing cardiac exercise to help with, reducing your cardiovascular risk. Strength helps your bones. All exercise is good for mood. And sleep, going back to where we started. But don't do vigorous exercise in the evening, but having exercise overall is really helpful. And eating well is important as well. And I know there's like increasing research into microbiome and the impact that has on your menopause, or the menopause has on your microbiome, but how that impacts you overall. So eating well, not smoking, not drinking too much. It's kind of putting everything all together, really.
Yeah, I think COVID's been a killer for a lot of people on the alcohol front.
Yeah. Huge. I think it's just kind of, it's getting the right balance. And it's also, though, not doing everything all at once. You can't change everything all in one go. You need to do something that feels achievable as well. So it may be you don't want to make any lifestyle changes because you feel rubbish, and then you start HRT and actually feel much better and much more able to then build in, exercise and everything else that goes alongside it.
Yeah. Yes, exactly. One more question here from Lana. She's asking, which estrogen gives the most steady dose of estrogen, and how does Sandrina compare to estrogen? That would be a very individual thing, would it not?
It's very individual. Patches usually give the most consistent dose because it stays. So you change them every 3 or 4 days. So usually every 3.5. But because the hormone's on a matrix, so you get the same amount all across the patch. And as long as it's applied properly, you get a steady dose of the estrogen. And so particularly for things like migraines, which can get worse in menopause, patches tend to be the best. Not always, but it tends to be, because it just gives a steadier dose. Whereas with the gel and the spray, because you're applying it every day, you will get some variation in dose. But it also, as you say, does depend on how you absorb. So it may be that we think the patch gives a more steady dose, but you feel better on the spray than the patch. It's how. And the other thing that is important is application and how you're doing it. It's like you're saying, so Sandrina is the little sachet of estrogen. Estrogel comes in a pump. But when you put it on, allowing it to dry, don't rub it on like that, because it won't.
There's an endless debate about this. People say, no, I rub it in really hard. And others are like, no, leave it to soak.
Yeah.
Do you find as well, do you think that maybe people find their absorption is worse in winter because they're cold? They don't have the sort of peripheral vascular supply.
Absolutely. And also you probably put your clothes on much more quickly because it's colder. And especially if you're using 4 pumps of gel, it's quite a lot. Someone was telling me today, she's like, so I'm quite used to walking around with my 4 pumps and waiting for it to dry. But when it's really cold, like especially at the moment, of course you're waiting for it to dry, but you may get dressed more quickly and it may go into your clothes a bit more effectively as well. So it's you've got to have the time to let it soak in if you're using the gel, which when it's cold, it isn't always that brilliant.
No, I know. I live in leggings, even though I don't do as much exercise as I should. I'm a bit like that. You know, I was at Little Britain years ago where they had the character who was sort of always hanging around in sporting clothes with a fag in one hand and a can of beer in the other. I'm a little bit like that. So I'm sure that my leggings are well and truly estrogenated.
I think
Yes.
when it's like, what was it this morning, -2? Probably much more elsewhere. I live in London. I'm sure it's absolutely freezing everywhere else. But yeah, when you're putting it on, you do need to wait for it to soak in. And like the patch, make sure that it's smooth, make sure your skin's at body temperature. And then you can rub it in your hand for like 30 seconds before and then rub it onto the skin, making sure it's well stuck on. So that definitely does make a difference in how it's absorbed.
And it doesn't matter where you stick the patch, really, as long as it's stuck on. As long as it's sort of as long as it's stuck, does it really matter where you put it?
People find it can absorb differently. So it needs to be below the belly button. So either kind of lower tummy, bottom thigh. I find it like over your pocket, like every pocket on your bottom is a good area to do it. You don't want it to catch on things as well. So you can find it can absorb differently in different. Sometimes it makes absolutely no difference, but for some women they find it can absorb better in some areas than others. So if you're using a patch going, doesn't feel quite right, just try putting it on somewhere else and rotate it around. Don't apply it to the same place each time. So put it on a new place. And if you get like black, sticky bits, you can use baby oil to scrub that off. But yeah, rotate it around to help with the absorption as well.
Yeah, somebody put a new product on the market actually for getting the stuff off. And I was thinking, why do you need this baby oil? But there you go. We have all these wonderful things. We have gone over time on Instagram, so I'm going to end that here now, and then I end that there. So thank you, Instagram people. And I will end this here with you. So if people want to find you, darling, where do they find you? Because I want to make sure that that's safe. So where do they find you if they want you?
So for consultations, I'm a Miss Claire Mellon, an associate at the Portland Hospital. So we can share a link, but so I'm there Tuesdays, Wednesdays. So I do face-to-face or Zoom as well, telephone calls. So that's my main clinical practice.
Wonderful. Brilliant. Look, thank you so much for that. And we should do this more often.
We should. Thank you so much. It's really interesting. Thank you for inviting me.
My pleasure. I will end that here, and hopefully I will talk to you soon. Take care.
Excellent. Have a good evening.
You too.